My name is Mike McNitt-Gray from UCLA. The title of this presentation is Assessing Radiation Dose, How to Do It Right. The next slide is my disclosures. Next. CT has some specific dose definitions in the computer tomography dose index. So we're going to talk first about CTDI and its cousins, CTDI 100, CTDI W, which is the weighted CTDI, and CTDI of All, which leads to dose length product, or DLP, which leads to some estimates of effective dose. Those show up in dose reports, which I'll go through some examples, and we'll talk about a future dose metric from task group 204 from the APM. So let's start with CTDI, or the Computer Tomography Dose Index. CTDI has a very specific definition, and it represents the average dose along the Z direction at a given point in the scan plane over the central scan of a series of scans, where the series consists of a large number of scans separated by the nominal beam width, as in contiguous scanning. Now, I put that long description in there to say it's a very specific definition, and it's not a very broad definition. It can't be used broadly. It means something very specific, and it does not represent patient dose. The phantoms that we use for CTDI are a body phantom, the 32 centimeter phantom. On the right you can see there's a large phantom and there's a smaller phantom, the head CTDI phantom. There's holes in the center and at 1 centimeter below the surface. This is what we use for the computer tomography dose index measurements. Next. CTDI 100 is made with a 100 millimeter chamber, ionization chamber, and it falls into this nice equation of 1 divided by NT, and it's the integral from minus 5 centimeters to plus 5 centimeters of the dose profile. Well, luckily that turns into a very simple algebraic equation that has this component. It's equal to these terms, F times C times E times L divided by NT, and I'll define each of these terms right now. F is a conversion factor from exposure to dose in air. So CTDI 100 is a dose in air measure, and that typically uses 0.87 rad per Roentgen, or the appropriate value for milligray per Roentgen. C is the calibration factor for the electrometer. It's typically around 1, though it can be higher for depending on the electrometer and the ionization chamber combination being used. E is then the measured value of the exposure in the ionization chamber in either Roentgen, or if it's properly scaled to in milliroentgen. L is the active length of the pencil ionization chamber, which is typically 100 millimeters. N is the actual number of data channels used during the scan, and T is the nominal width of each data channel. So N times T, the product of that, is the nominal beam width, the nominal collimation width being used at that time for the measurement. CTDI measurements are done in both head and body phantoms. They use only a single axial scan technique, because CTDI is actually the area under the single scan dose profile. That's where that integration comes from. So this is measured at isocenter and at least one peripheral position in each phantom, so typically done at the center position and the 12 o'clock position, and it's done in both the head and body phantoms. CTDI-W is the weighted average of center and peripheral 100 to arrive at a single descriptor. And here's the equation. CTDI 100 equals 1/3 of CTDI 100 center plus 2/3 CTDI 100 at the periphery. Next. CTDI of All is a calculated value. It's not measured directly. It's based on that CTDI-W of the previous slide. It's measured from a single axial acquisition, but it's calculated with a pitch value. So you have to think of this as the pitch value that you would have used if you were performing a helical scan. That's typically the pitch value from the helical scan protocol. But please be clear, CTDI is not defined for a helical acquisition, the measurement itself. This calculation that I'm going to show you in the next slide takes into account the conversion from the axial scan that you do to the helical scan using the pitch value, as you'll see. So CTDI of All is very simply CTDI-W divided by pitch. In the context of automatic exposure controls, such as tube current modulation, CTDI of All has a very specific meaning. When tube current modulation is used, the CTDI value reported is based on the average tube current used throughout the scan. This is essentially the CTDI of All at that specific set of conditions of KV, bow tie filter, collimation, rotation time, and then uses the average MA across that scan, because CTDI is very linear with MAS. To illustrate that, let me show you this figure here. In the light color, the white or blue, light blue, is the actual tube current from a tube current modulation scan set against the background of the patient's image data reconstructed in a sagittal plane. The red line represents the average MA per rotation that's extracted from the DICOM header of the set of image data. So you'll see the white values, the actual tube current, oscillating up and down very rapidly, and the red tracking that, but on a much slower change, because it's representing only the change along the z direction. By the way, the x direction in this plot is the taper position in millimeters, and the y-axis is tube current in milliamps. The yellow line represents the average tube current taken across the entire scan, and I think you can see that from this illustration. The CTDI of All then is going to be based on this single value, the average tube current in yellow. That's the average across the entire scan performed. The dose length product is simply just what its name says. It's the product of dose, in this case CTDI of All, and the length, which is the length of the scan. And it's in the units of milligray centimeters, not milligrays per centimeter. It's milligray centimeters. It's found in most dose reports and does include any overscan or extra scanning that's used for helical scanning. Effective dose is a concept that a lot of people refer to, especially in the context of CT. Most CT scans are partial irradiations of the body. We don't irradiate the entire body. So how to compare the effects of different exposures to radiosensitive organs? So effective dose tries to take this into account by using the absorbed dose to specific organs and the radiosensitivity of each organ. Please note that the effective dose concept is not intended for dose to an individual. It is really meant as a dose for a population of individuals, not for a specific individual. So we don't encourage the use of effective dose on an individual by individual basis. The formula for effective dose looks very simple. It is the sum, that symbol sigma there, is the summation, and the subscript T there is for the tissue, so it's the summation across all tissues of this product inside the parentheses, where WT times WR times this capital D with the subscripts T and R. So WT is the tissue weighting factor, which I'll describe quantitatively in the next page, but it's the weighting factor for each of the radiosensitive tissues. W sub R is the radiation weighting coefficient, which is just 1 for photons. Capital D with subscript T and R is the average dose to tissue T from radiation R. In this case, again, we're just talking about X-rays for CT. So it's only a weighting coefficient of 1, and it's the absorbed dose just from the X-rays from the CT scan. The units the SI units are in sieverts. There are English units around that are still around called rem. 1 rem equals 10 millisieverts. We're typically in a millisievert range within CT. Here are the weighting factors. ICRP 60, which was issued back in 1991, has tissue weighting factors. ICRP 103, which was issued in 2007, adjusted a couple of these weighting factors. You can see the gonads went from 20% weighting factor to 8% weighting factor under ICRP 103. Breast went from 5% in ICRP 60 to 12% under ICRP 103. And you can see the remainder also went from 5% to 12% of the total in ICRP 103. So you can see the weighting factors there. To estimate effective dose accurately, you would really need to estimate the dose to each radiosensitive organ, and you'd need to do that accurately, which is really difficult. So some of these values come through Monte Carlo simulations. So next. To estimate effective dose, there are some computer software packages out there that are based on Monte Carlo simulations, such as the Impact Calculator or Impact Dose simulation package. We hear a lot of discussion about the K factors, which were originally based on the dose length product derived from simulations, and the formula is that the effective dose E equals the dose length product times a K factor, where K is in the units of millisievert divided by milligray centimeters. K is 0.0023 millisievert per milligray centimeters for head exams. K is 0.015 for abdomen, and you can see AAPM report 96 for other K factors that are adjusted by age and anatomic region. What's a typical reference? About 3 millisieverts per year from background radiation across the United States. That's from natural sources such as radon and cosmic rays. Mettler et al. Now estimate about 3 millisieverts per year from medical procedures as well. So in the United States, an average annual exposure for the entire population is about 6 millisieverts total, 3 from background, about 3 millisieverts from medical procedures. So let's talk about CTDI of All and DLP. CTDI of All is reported on a scanner. It is dosed to one of two phantoms. It's either the dose to the 16 or the 32 centimeter phantom. It is not dosed to a specific patient. We'll talk more about that in a few minutes. And by itself, it does not tell you whether the scan was done correctly or even a LARA without some other information, such as body region or patient size. And please see the editorial that Dr. McCullough and some of myself and other colleagues wrote in Radiology in 2011 about the CT dose index and patient dose, that they're not the same thing. Here, just to illustrate that point, here is an example. Let me give you two scenarios. In scenario one, let's say we don't adjust the technique for patient size. And so we have a small patient on the left and a large patient on the right. And let's say we use 100 MAS on both of them. The dose to the phantom, which is what CTDI of All is 20 milligray for the patient on the left and 20 milligray for the patient on the right. So the dose to the phantom for these two would be the same. In scenario number two, where we do adjust for patient size, let's say we give 50 ampere seconds, 50 mass to the patient on the left and keep it at 100 MAS for the patient on the right. The dose to the phantom would be less to the patient on the left and remain at 20 milligray for the patient on the right. So the dose to the phantom in these two scenarios is different, and it indicates the larger patient received twice the dose. But in fact, did the patient dose really increase? Scenario one, the CTDI is same, but the smaller patient's dose is actually higher, as we'll illustrate in a few minutes when we look at TG204's size-specific dose estimate. In scenario number two, the CTDI is smaller for the smaller patient, but patient dose is actually closer to equal for both of these two. So looking at CTDI and not taking into account the patient size does not give the complete picture. So let's talk a little bit more about CTDI of All. It is not patient dose. By itself, it can be misleading. The CTDI of All should be recorded with the description of the phantom size, clarify whether it's a 16 or 32 centimeter diameter phantom, and the description of the patient size, lateral width, perimeter, height, weight, BMI. Some description of patient size is really appropriate here, and a description of the anatomic region. Here's an example of a dose report. Here is highlighted in the yellow circle is the total dose length product of 489 milligray centimeters. You can see, if you look down a little bit below that, you can see on the left there's a description that says brain without. That's the kind of study that was performed. You can see the KV. This is from one of our Siemens scanners, so it reports the MAS and what we refer to as the quality reference MAS. Quality reference MAS is the setting. The 206 MAS is the actual average MAS across that scan for that head study. The CTDI of All value is reported there as 26.77. The B next to it, if you look down at the bottom of the page, describes the phantom type. In this case, it was the 16 centimeter phantom, and it gives the dose length product of 489. Because there was only the one sequence, that's the same as the total dose length product. Here's a more complicated study with several sequences. In fact, you can see the total dose length product here is 2,331 milligray centimeters. That's the total of the dose length product values shown over towards the right of the page. If you went down and summed from each of the sequences, you would get that 2,331. I do want to point out that the monitoring study, midway down the page, is listed as scan number 10, 120 kV, 20 MAS, but it gave a CTDI of All of 143 milligray. Notice that it's a B again with the 16 centimeter phantom. Has a very small dose length product because the monitoring study is that study that's done after the injection of contrast, waiting for the contrast to reach a certain level of enhancement before the rest of the scan is performed. The CTDI really is an overestimate, which I'll talk about in just a minute there. But it just shows that even though it's a very low technique, it was repeated a number of times there. Please note that the C-spine portion of this scan uses the CTDI of All for the 32 centimeter phantom. You can see that next to the C-spine line, the CTDI of All there uses type A. And all of the others use a type B phantom, which is the 16 centimeter phantom in this nomenclature from Siemens. Okay, so which phantom was used for CTDI? Currently, all manufacturers for head exams, either adult or pediatric, use the 16 centimeter phantom. All adult body scans report with the 32 centimeter phantom. Sometimes there is confusion about the pediatric body phantom. So you should be careful when looking at pediatric body scans. Siemens and Philips have reported this CTDI of All based on the 32 centimeter phantom. GE and Toshiba have reported either 16 or 32 centimeter phantom, depending on the scan field of view. Please note that the CTDI of Alls can differ by a factor of 2 or 2.5, depending on whether you're using the 16 or 32 centimeter phantom. The IEC has set a standard for 32 centimeters for all bodies, pediatric or adults, and 16 centimeter for all head scans, adult or body. But it'll take a while for this standard to permeate through existing scanners and existing softwares. Please be aware that this affects the DLP as well. So what should be reported? The individual CTDI and DLPs, the total DLP, the total CTDI of All. Let's go through a couple of examples. And the issue is really, what do you need to do? In California, we have to meet state regulations. We have a state law about reporting CTDI. So the question to you is, do you have to meet state or local regulations for this? And what do they require? Or are you recording and reporting dose because it's the right thing to do? And recording CTDI of All and patient dose, because remember, they're not the same thing. To comply with the California state law, we only need to report CTDI and DLPs. The state has given some flexibility there. In our own institution, we report the individual CTDI and DLP values. We're not required to report the total, but we are required to report CTDI and DLP. When does it make sense to add CTDI of Alls? When the same anatomic region is scanned repeatedly and the assumptions of CTDI apply. That is, there is table movement, you're scanning through an anatomic region, such as a head or a chest or an abdomen. And so some example would be a non-contrast chest followed by a post-contrast chest. That would be a time when it would be appropriate to add the CTDI of Alls. When does it make sense not to add the CTDI of Alls? When you're doing different anatomic regions. When you scan the head followed by the abdomen pelvis, it does not make sense to add the CTDI of Alls. Or when you're doing no table motion, such as a perfusion scan, then it does not make sense to add CTDI of Alls, because when you're doing a perfusion scan with no table motion, that violates the assumptions of CTDI of All, which is that contiguous scanning. When does it make sense to add the DLPs, similar to CTDI of Alls? When the same anatomic region is scanned repeatedly and the assumptions of CTDI apply. When does it not make sense? Again, similar to CTDI of Alls, when they're different anatomic regions. Adding chest to abdomen may be okay. Adding head to body is a bit of a stretch. They're done on different phantom sizes. So adding dose from a 16 centimeter phantom to that from a 32 centimeter phantom in DLP seems a little bit of a stretch, but it's often done. When there's no table motion from a perfusion scan, this also violates the assumptions of CTDI of All and DLP. Let's talk about one last topic, which is APM Task Group 204, the size-specific dose estimate. This is a report that came out in 2012 with John Boone as the chair. And what The APM task group report 204 defined was this size-specific dose estimate, which is this curve illustrated on this slide. And on the x-axis, you can see the effective diameter measurement, which takes into account it's a metric of the size of the patient, and the y-axis is the normalized dose coefficient. This is the number that you multiply the CTDI of All reported on the scanner, you multiply by this coefficient. So you can see that, for example, if it's a 32 centimeter effective diameter patient or a 35 centimeter effective diameter patient, that the normalized dose coefficient is 1. That means you would just use the CTDI of All reported by the scanner using the 32 centimeter phantom. If it's a much smaller patient, let's say a 15 centimeter effective diameter patient, then you would have to multiply that CTDI of All value by a coefficient of approximately 2 to get the best estimate of the size-specific dose estimate. So this is taking into account the effects of size when reporting the dose for the patient. This report also describes coefficients based on lateral width and AP thickness, and it has conversion coefficients for both the 32 and the 16 centimeter phantom. One other thing is, when does CTDI of All indicate peak dose? Again, according to the original definition, CTDI of All was the weighted average of measurements made at the periphery and center of a cylindrical phantom, and it was defined to reflect dose from a series of scans performed with table movement. So if you look at the scans indicated on the graph on the right-hand side, where you do a series of scans, the tails of those little dose profiles overlap, resulting in an increased dose to the entire region, and that line representing CTDI of All, CTDI 100, represents the average when you're scanning through a large region. If you look on the left-hand side, the peak dose from an individual scan with no table motion is much, much lower, typically in 50 to 70% of what the CTDI 100 value would be. So CTDI of All is a weighted average. It's defined to reflect that dose from a series of scans. It's not patient dose, even when you're thinking about perfusion scans, and typically overestimates the skin dose where the scan is performed with no table motion, such as a perfusion scan. So how to do this right in reporting dose. This is my editorial comments here. Let's start at the bottom and work our way to the top. In phase 0, some of us are currently here, where we have the patient protocol page, and that information is dictated directly into the radiology report. That's one way to report dose, and that's how some people are complying with the state law in California. In phase 1, some of us are here. The DICOM structure report is communicated. Those values are also dictated into the radiology report, because some scanners create DICOM structure report, but it's not easy to read and dictate. In phase 2, our institution happened to get here by July 1, which is when our law went into effect, where we had DICOM structure report, but we also had the patient protocol pages, and we had a way to auto-insert them into the radiology report. But this was just CTDI of All and DLP values. In phase 3, which I hope will come next in not too distant future, the DICOM structure report will be sent automatically. They'll be body region and size adjusted and automatically inserted into the radiology report. And in phase 4, sometime in the future, we'll actually make this body size adjusted and make estimates of organ doses and find a way to communicate that effectively and have that auto-inserted into the radiology report sometime in the future. In summary, CTDI of All and DLP are widely available. They're in all the dose reports. It's dosed to a reference size phantom. It is not patient dose. It does need to be adjusted for patient size, and we need methods to determine when to add CTDIs and when not to, especially in an automated fashion, so this could be done robustly. And also, it is not skin dose. It overestimates skin dose for perfusion scans by either 50% or at least 30%, depending on the study that you're looking at. Effective dose is also out there. It was meant for population doses, and it is not meant to be used as a measure of dose to individuals. And with that, I will conclude. Thank you.